Welcome to Community Health Matters. I'm your host, Amy Marsalis. On today's show, we'll learn about Medicare Annual Enrollment, lung cancer, and epilepsy. All of that coming up next on Community Health Matters. From the News Channel 5 network, this is Community Health Matters, sponsored by the United Health Foundation. Hi, everyone. If you live to be 65, Medicare is going to be very important to you. And if you're already 65, you may have some questions. Greg Kuhnman is with United Healthcare, and thank you so much for coming in to help enlighten us more about Medicare.
Great, thanks for having me.
Sure thing. Tell us out of the gate here, what is it and why should we care about Medicare?
Well, some interesting facts about Medicare. Number one, there's over 54 million people enrolled in it today. And in Tennessee alone, 1.2 million. So Medicare is a federal health insurance program, really for people over age 65 or due to disability.
So you could be under 65 if you have a certain disability?
Yeah, due to disability, yes, there's certain conditions and they could be eligible for Medicare.
Okay, so there is a pretty wide net then in terms of eligibility.
That's correct.
Okay.
About 85% are 65 plus.
Okay. Now for seniors and other people who are enrolled in Medicare, why is annual enrollment so important? So you have this time period every year to enroll. Why is that critical?
Yeah, for most seniors on Medicare or anyone on Medicare, they have one time per year to make changes. So it's really key during the open enrollment period, which begins on October 15th and runs through December 7th, and that would be for elections in 2019. So what happens if they don't make any changes, which they don't have to, it's really a checkup period. So even if you were working and you go through an open enrollment at work, the seniors and those on Medicare could just check their health plan that they're on today and ask them, just simple questions. Is it meeting their needs? Are their needs going to change? And what happens is if they don't make any changes, it could roll over into the next year. And that could be good, or maybe something that if there was some changes, it may not be so good. So really, it's just a time for them to do that checkup.
I saw on the graphic, it talked about the budget and different considerations. What might be some other things that would affect you making changes?
Well, first I would start, a lot of people think Medicare is confusing, and my mom and dad are part of that. And we found at United Healthcare over 40% of people think Medicare is confusing. So we're going to walk through some simple steps to make sure that it isn't confusing. So I would first start with, from a health standpoint, is your health plan today that they're on in 2018, is it meeting their health care needs? And are those needs going to change in 2019? So that would be one. The second thing could be financial. And it's not just premiums that you're going to pay for Medicare, but it could be your co-payments, your deductibles, and your cost share. Are those things going to change? So for most people on Medicare, whether it's the drug plan or Medicare Part C plan or Medicare Advantage, they should have received an annual notice of change, and it will let them know the changes between 2018 and 2019. The other things I would start, so we did health, we did financial, and then look at your prescription drugs. There's things such as drug lists and formularies. Are the drugs you're taking on your plan today, are they changing, and are those costs changing?
Because obviously people, the status of your health can change dramatically in the course of 12 months.
Right, that's correct. So that's why you kind of look at all those. You want to make sure your doctor and your hospital's in the network. And there could be some other things that Medicare may not cover that for example, a Medicare Advantage plan would. So it could be a fitness benefit or dental. So I would just do those simple things. Make sure you understand that window, because it's really important, between October 15th and December 7th. And they don't have to make a change. You could stay on that plan if it's going to meet all those needs, or you may want to look at it, because Medicare isn't a one-size-fits-all. In fact, my mom and dad have different plans, based on their needs.
Okay. Now, we've all heard of Medicare Part A, Part B. Explain what all of that means, the difference between A and B.
Right. Well, we take our seniors and those on Medicare back to school. So Medicare basically has four parts, if you think of it. Medicare Part A is your hospital and your skilled nursing facilities. Medicare Part B are your physicians and your outpatient. And that part covers 80%, so you would have a cost share of, say, 20%. Medicare Part D, as in dog, is a prescription drugs, and that covers obviously your drugs. And the last one is a Medicare Part C. So there's actually 4 parts, which is Medicare Advantage or Medicare Part C plans. And most of those plans, they're a combination of your A, B, and D all into one. So you have basically Medicare A, B, D is your drugs, and C is a Medicare Advantage.
Okay, I see that. Good breakdown on the screen as well. The graphic helped break that down as well. Medicare Advantage also, it's one of the options people can consider. And I understand it's experienced rapid growth in the enrollment over the years. What is Medicare Advantage and what's driving all of that growth?
Yeah, so Medicare Advantage are also known as Medicare Part C plans, and they're run by private insurers like United Healthcare. There's over 10,000 people today aging into Medicare, and the boomers have found Medicare Advantage very popular. In fact, out of those 54 million plus enrolled in Medicare, 1/3 are in Medicare Advantage plans. And some of the reasons they're so popular, one is just ease. You have one card and it covers your A, your B, and also your drugs in most cases. So it's convenience, there's fixed co-payments. And most seniors have found in those on Medicare that Medicare Advantage plans also cover things Medicare may not, traditional Medicare, which could be a dental. United Healthcare has a house call program, fitness benefits, vision and glasses. So it covers additional services that you may not receive under a regular Medicare.
I see on the, can we go back to the graphic for just a second too? I see where it says maximum out-of-pocket limit. Let's
Correct.
talk about that a little bit.
Right, because when we talked about Medicare A and B, I talked about the 20% co-insurance. You could pay that, for the entire year. Medicare Advantage plans do have an out-of-pocket limit. It could be as high as $6,700, and if that's the case, if you meet that amount, which is quite high, but after you met that amount for your Medicare A and B services, your payments would be zero, and everything would be covered at 100%. So there is some fixed costs associated with it, so that you're not going to have a whole lot of dollars spent each year.
Okay, now people are facing obviously some pretty important decisions over these next few weeks, the enrollment period. So what are some resources that they should be aware of to help support them as they make these critical decisions? They really are critical decisions.
Yes, and there's a lot out there, community services. I love a website called Medicare Made Clear, and I do that for caregivers and boomers aging into Medicare. It's kind of a Medicare 101. It just walks you through some of the things we talked about.
Medicare for Dummies? Sorry, no,
Medicare 101.
Okay.
So that's Medicare Made Clear.
Okay.
UHC Medicare Health Plans is a good website during the open enrollment period where they could research our plans. There's also a phone number they can call, 1-800-UHC-6509. So there's a lot of community sources out there that they could use those websites I listed.
Well, your folks are lucky to have you in the position you're in to walk them through this. And, what has their feedback been?
Yeah, my mom and dad, my neighbors, the people I go to church with. My brother's a boomer. He's aging in, so I was with him this past weekend. So I always tell them, take a deep breath. I'm going to help them. I've worked in Medicare for 30 years. It's changed. It's evolved over time. But just ask those basic questions. Is the plan they're on today meeting both their health and their financial needs? Are those needs changing? What's available out there? And do their research. So don't be afraid to use community resources. There's agents in the field, and there's local meetings that United Healthcare has. They can go on our websites, and there'll be licensed agents that could go through that. And really, at the end of the day, they may be happy in the plan they're on today, and they don't need to make a change. But if they want to, use that time frame in order to do that for 2019.
All right, thank you so much for this tutorial. Very, very helpful. Thanks,
my
Greg.
pleasure. Great to be here.
All right, and we'll be back with a lot more right after this. November is Lung Cancer Awareness Month, and Dr. John Howington is a thoracic surgeon at St. Thomas who came in to talk to us about lung cancer. Nice to see you.
Nice to see you. Thank you for having me.
I know the majority of the cases are smoking related. Give us the breakdown on who is primarily affected.
So the majority of lung cancer patients are either primary or secondary smoke exposure. That's about 87%. But just over 10% have never smoked in their life. And when there are 240,000 lung cancer cases a year, that's close to 30,000 people a year that never smoked. So it's an important group for us to focus on. but far and away, the #1 cause of lung cancer is smoking.
So that is the greatest risk factor by
Correct.
far.
Yes.
Okay, secondhand smoke, where does that fall in risk factors?
So we saw it mostly in the wives of smokers, because typically adults, when they smoke, try to avoid smoking close to their children, but spouses get most of that secondhand smoke exposure.
What about for those of us maybe who had grandparents who smoked a lot when we were young? You were exposed to that a lot when you were little kids. Are people of my generation at greater risk because of that exposure?
We've not found that among children of smokers, that they are at increased risk. It's primarily been people with occupational exposure, secondhand smoke, so bartenders, people in jazz clubs that when they used to have smoking in clubs, or the spouses of smokers.
How would you know? What are some of the symptoms? The first thing I would think of would be a horrible cough. What else?
And most of the symptoms of lung cancer are non-specific, so like a cough. Smokers typically have a cough, but this would be a change in the character, or it just lasts longer throughout the day. Someone that never had a particularly chronic cough, just having a persistent cough that lasts for many weeks, and not other symptoms like a cold or a flu.
I see also on the screen you may have chest pain, hoarseness, weight loss.
Yes, these are all signs of advanced lung cancer. And you know, the symbol or ribbon for lung cancer is clear, because lung cancer, until it's advanced, doesn't cause symptoms. There's not a lump, there's no general feeling of being bad until it becomes advanced. So that's why lung cancer screening is important.
And who would be asking for lung screening? You know, what patient population? Obviously, smokers, as a rule, I would think maybe wouldn't necessarily ask their primary care physician to be screened. Would the primary care physician be looking for that?
Well, they both should be part of the conversation. Yes. And so if you're 55 or older and you smoked a pack a day for 20 years or longer, and you're still smoking or you quit in the last 15 years, then you should have that conversation with your primary care physician. And we know from lung cancer screening trials that you got a 20 to 40% chance of reducing your risk of dying from lung cancer. And we know that lung cancer is the #1 cancer killer in women and men. And for women, it's an even greater benefit. There's a 40% reduction in lung cancer mortality in women that get screened for lung cancer. Higher than for breast cancer screening or for colorectal screening.
Is that fairly new information?
Yes, that's brand new, hot off the press from the World Lung Cancer Congress. There was a 15,000 patient trial in the Netherlands, and that showed in women a 40 to 60% reduction in lung cancer mortality if they were screened.
The best screening tool, it's not an X-ray.
Correct, it's a low-dose CT scan. We knew from trials in the 70s and 80s that chest X-rays are just not sensitive enough. But with the low-dose CT, you can identify lung cancers early, the vast majority in stage 1. And early-stage lung cancer is highly curable. 80 to 90% of patients with stage 1A lung cancer are cured. So with lung cancer screening, we can change the culture, the paradigm of lung cancer. Just like breast cancer, early-stage lung cancer is highly curable.
Are you finding them earlier and earlier with the CT scans?
We are, and so we're seeing a stage shift. Not as fast as we'd like, because not as many patients are getting screened as they should. Less than 10% of people that are eligible for screening are currently getting screened. So that's why programs like this, lung cancer awareness, to get the word out for patients that are at risk to get screened.
What are some of the most effective treatments? Is it targeted therapies, drugs?
So it's stage-specific treatment. So for early stage, stage 1 and stage 2, it's typically an operation. If it's stage 1, it's just the operation and following you closely for any chance of recurrence. Stage 2, it's typically chemotherapy after the operation. For more advanced stages, it's a combination of chemotherapy and radiation, and you're correct. In the advanced stages, very promising findings with targeted therapies, immunotherapy, and so we're seeing, even in the most advanced stages, with current treatment, longer survival, longer periods of remission, and less side effects from the therapy.
That's encouraging to hear this.
A lot of positive news in the last decade on lung cancer.
Sounds like it. If people need help in putting out that cigarette for good, what do you recommend? So
there is the 1-800-QUIT number to call. There's also help through cancer.gov, the American Lung Association, the American Cancer Society. All those websites have links to help smokers quit smoking.
If you have a smoker, a heavy smoker in your family, if it's a parent, grandparent, a coworker, do you think it's a good idea to say to them, hey, talk to your doctor about getting a CT scan specifically? I mean, do you think that's good advice?
Yes, I'm actually the youngest of 8, and I have several siblings that fit the criteria. So yes, I talk with them to have a conversation with their primary care physician about getting lung cancer screening.
All right, best place to go for help as far as a resource?
So they go to stthomashealth.com, then go to cancer.gov, and again, the American Lung Association or the American Cancer Society.
All right, thank you. This was very enlightening, and I'm so pleased that you shared the news out of the conference as well. That gives people more hope.
Yes, very, very much a more positive paradigm for lung cancer today.
Okay, thanks so much for coming in and sharing
Thanks
this
for having me.
information. Appreciate it. We'll be back with a lot more after this. So glad to have my guests here today to talk about epilepsy. They're both with the Foundation, Pam Bryan and Susan Holloway, and both of you are involved with the Epilepsy Foundation of Middle Tennessee. Thanks for coming in.
Thank you for having us.
Let's start with Pam. What is epilepsy? I know you're a caregiver for your son. Tell us about his situation, how you got involved.
Okay. My son, 27 years ago, was in a car crash when he was 13. He sustained a severe brain injury and a spinal cord injury, and as a result of the brain injury, he does have seizures. So that's how it led me to want to help others, to give back. Epilepsy is a neurological condition that affects the nervous system. Individuals are diagnosed with epilepsy if they have at least 2 seizures. What's important to know is that epilepsy is not contagious and that it is not a mental health illness.
And Susan, not all seizures are the same. We know that. And what are some common types of seizures?
Oh, there have been stated by United Kingdom in some of their videos that there's 40 different types. I call the national organization for ours here in the United States, and they say, well, we've never put them all together, but there are a lot. For example, if I'm blinking and I'm just kind of tuned out blinking, that could be a seizure. If I'm wringing my hands, if I'm sleepwalking like, it could be a seizure. All of these different types of things could be a prerequisite to a major seizure that we know of as clonic-tonic, where we are on the floor. Used to be called a grand mal.
That was what I was going to ask you about. That was most
and
familiar.
most people know it as that, but it's been changed to clonic-tonic because of the tight muscles and the jerking. And that's where the names come from. So there's many different kinds, and I, as a teacher for 36 years, was never taught to look for those things in my class. I might have just thought somebody was taking a nap or whatever.
Distracted.
And distracted, get tired, sleepy, and it's not may not be so.
So Pam, in your son's case, it was brought on by the accident and the brain damage, correct?
Right. Correct.
What other causes are there for epilepsy?
Other causes are strokes, Alzheimer's, illnesses that cause problems in the brain, such as encephalitis or what's the other, meningitis. There's just tons of genetic factors can cause seizures, and 6 out of 10 have no known reason for them having seizures.
Could that be genetic factors that people aren't aware of?
Yeah, and doctors run all kinds of tests, and it's frustrating to the individual to not know why they're having these. But
Of course.
the good news is that they are treated. They are able to treat these seizures with seizure medications.
That's the good part of it. Okay, so how is it diagnosed? Either one
Well,
of you.
the interesting part of that is I've been 5 years now teaching classes with the Epilepsy Foundation. One day, an elderly couple in their 80s came up to me after I had given the class, and she was pulling him along saying, come on, you've got to go see if this woman knows exactly what you've been doing to me. You've been ignoring me, you've been shutting your eyes, you've been all these things. So she was getting on to him for the way he'd been acting. He was just smiling and coming along behind her. They wanted me to diagnose if he had epilepsy or not. And the thing that I had to tell right off was, you, ma'am, are going to become a very big factor in the diagnosing of him. You're going to write down every time he has a seizure. You're going to take how long it lasted. You're going to talk about what maybe happened before. Was he working in the yard and he got real hot? Or all these sort of things. And then you're going to take that to a medical doctor, because I cannot do that. Only medical doctors can diagnose those. They may use some tests.
So you almost need to journal it.
Yes, yes.
To keep track of what's going on, a diary, if you will. How is epilepsy then treated? You mentioned there are drugs.
Right. We do
Is
have
that
medicines.
are the medicines pretty effective?
With maybe 60% of the people.
60%.
And the other, types of people are just at, what to do without medicine. So then they've come up with many other things. And some of them are a piece of equipment. They have like the VNS, the
Vagus nerve
RNS.
stimulator.
These are all little mechanical things that are implanted different places,
I see.
and they then catch the flow of the electricity currents and help diagnose what's going on. They a lot of times make them less effective, or like, for example, if you were going to have a seizure and the VNS was hooked to a nerve. Well, it then sends a message to the brain not to do what it's doing, and it helps lower it some. So there's all kinds of things like that we're doing.
I see. What are some tips if you see someone having a seizure, but you're not familiar with seizures and that particular patient? What do you do?
The first thing to do is the hardest thing to do, and that is don't panic. Remain calm. My son's had seizures for 27 years, and if he had one today, it'd be just as frightening for me as the one he first had 27 years ago. But there are ways you can help. You feel kind of helpless when somebody's having a seizure, but some of these ways are, first, time the seizure.
Time it.
Time it. From the minute it starts to when it ends. This is very important. Make sure if the person is having a tonic-clonic convulsive type seizure that they're laying down, you turn them on their side.
Okay.
You make sure there's no objects around them that could be dangerous.
Okay.
You put something soft under their head, because you don't want them banging their head on the hard surface, like a pillow, your coat, whatever soft.
Okay.
You just make sure that you stay with them until they're awake and
Till help
fully
comes.
alert.
Thank you so much, both of you, and I really appreciate you coming in. And thank you for watching Community Health Matters. Learn more ways to improve your health on our website, mycommunityhealthmatters.org. And remember, here in Middle Tennessee, our community health matters.